Hi, welcome to Psycho Bible. This is Andrew Rodriguez, and I'm excited to have another guest on my channel. This is Robert Vazzo. He's a therapist, colleague, and friend of mine, and that I met back in 2016 at my first conference with the Alliance for Therapeutic Choice and Scientific Integrity. And just quick memory, one of the highlights of that first conference for me was when I went out to dinner with Robert and David Pickup and a few others. And I was just blown away by the conversation as the two of them were just talking shop and sharing about cases and case conceptualizations. And it just became so clear to me that the therapists in this particular field, working with people with sexuality struggles, they know their stuff and they practice with the utmost level of professionalism and uh, just clinical intuition and skill. And so I've gleaned a lot from Robert over the years, especially later on when he and David Pickup as well did a training on image transformation therapy. So I've incorporated that into my practice. So I owe a lot to Robert just with what he's taught in different workshops. So I'm excited to have him on as we're going to dig into a particular topic that is very relevant to the work we do in this field. But first, Robert, let me just give you the opportunity to share a little bit more about yourself, the work you do, where you're located, all of that.
I'm a licensed marriage and family therapist and also a professional clinical counselor. I have that license in California. I'm also licensed as a marriage and family therapist in Nevada, Texas, Ohio, and Florida. And I do that because I have lots of clients in different places in the United States. So I try as best as I can to obey licensing laws.
Mm-hmm.
I've been practicing since 2004. And a lot of my work is helping men with same-sex attraction, but I also do work helping individuals with fetishes. And I
Yes.
think that's an area that you also have of interest and that we're going to talk about today.
Yeah. Now, your in-person practice, you're located in,
Las Vegas, Nevada.
okay. So, and you are seeing people in person as well as online.
Correct.
Okay.
That's right.
Well, Robert, yes, I asked you to join me today because I really want to dig into this topic of sexual fetishes. So, this is going to be pretty educational, particularly those who are coming from a client perspective as well as those who are clinicians. So, let's start with some basics. What's a Give us a definition of a fetish.
Sure. What I want to do first is give you a dictionary definition. And so I went to two dictionaries. I went to Merriam-Webster, and Webster defines a fetish, and I'm going to give you the definition for the sexual fetish. It's an object or bodily part whose real or fantasized presence is psychologically necessary for sexual gratification, and that is an object of fixation to the extent that it may interfere with complete sexual expression. So that I think is not a bad definition. That's encompasses some of what we're going to talk about today. Then there's another definition from Oxford. Uh, I find it less compelling.
Mm.
It says a form of sexual desire in which gratification is strongly linked to a particular object or activity or a part of the body other than the sexual organs. So what they talk about in both definitions is sexual desire, but those definitions for me are incomplete. And they're incomplete because they don't really get to the root of what a fetish really is.
Mm.
Okay. So they talk about sort of what a fetish does
Mhm.
and maybe how a person behaves when they have a fetish. But for me, and this is from years of dealing with individuals with fetishes, I define it as an object or an idea
Mm.
um, that gets eroticized unconsciously in the person's psyche. And the purpose of the eroticization is twofold. The first purpose is to ward off painful feelings associated with the object. And then the second is to make the associations that the object has or entails pleasurable. So what we find, for example, if I can just give you an example of a fetish being an idea, I've had clients, or I've known of individuals who like to be tied up and have pain inflicted upon them, or maybe they're masturbated, but the idea is that they cannot break free. And what we find in one of the interventions that I do, that I'm going to talk about in a minute, is we find that in their lives, they were sort of recipients of what's called a therapeutic double bind, or a double bind.
Mm-hmm.
And a double bind is a lose-lose situation. So they might have been in a family where mom or dad told them, you talk too much, you need to be quiet, or you're too aggressive. And then when they became meek, the mother or father would say, you're such a wimp, you're such a wuss.
Mm-hmm.
So it's hell if I do and hell if I don't. So in my work with clients with such situations, we have found these double binds. And so one of the also characteristics of a fetish is that it has caused pain or fear. So it's an object that gets eroticized, and the purpose of the eroticization is to ward off painful or fearful feelings associated with the object. So that's why I tried to take the dictionary definition and expand a little more on it.
Yeah. Have you found that there are other researchers, clinicians that are on the same wavelength with you as that fuller definition that you provided?
Most are not. So if you go in the Diagnostic and Statistical Manual and look up the criteria for fetishism, they talk more like the dictionary definition.
Mm.
You can tell there's an absence of knowledge of what this thing really is. We just know that it's a paraphilia. All fetishes are paraphilias. To have the diagnosis of fetishism, it can be anything except transvestic fetishism. That's a diagnosis in and of itself. We know they're paraphilias. Researchers know that somehow they get eroticized, but I don't think most people know how they get eroticized and how to heal them. And that's a problem.
Yeah, so what's the research base? Is there much literature on this yet?
I've looked at the research base. There isn't a lot. A lot of it has to do with who has fetishes. So men are more likely to have fetishes than women. A lot of it has to do with brain activity, so where the fetish is experienced. You and I were talking earlier about, in certain cases, the amygdala, of course, gets fired, and in brain scans, they can see that. So indeed, my hypothesis about pain or fear, I think, is true.
Yeah.
But there's not a wealth of information about fetishes. It tends to be surface.
Now, have you presented any of this to others in the field, particularly other marriage and family therapists, anyone else that
I have not done any professional presentations yet. It's on my to-do list.
are
I've had a
waiting for that?
lot of great conversations with people. It's difficult because in order to prove my hypotheses, you would have to be able to do an intervention. And I have one which uncovers the past pain. But believe it or not, often the client is unaware of any pain or trauma. So that's another important point. For me, all fetishes are connected to pain and trauma. They're not the normal expression of sexual desire. Because as we know, even if you're not religious, the purpose of sexual desire is to draw the male and the female together to have reproduction of the species.
Yeah.
So that being said, that's a very powerful force. For it to get sidetracked and derailed, something must have happened.
And that brings me to the hypothesis that I've been mulling over and I've been bringing up in my recent videos, that a maybe not a politically correct way, but a more accurate way of understanding same-sex sexual attraction itself is that it is a fetish. I mean, we see clients with SSA who tend to have fetishes, but I'm not just talking about that they tend to have a fetish, but that the SSA itself is fetishistic.
Correct.
In nature. So I want to get a little more of your thoughts on that, and what have you expanded that thought yourself?
Yes, I brought this up to Joseph Nicolosi, my former supervisor, at a conference in 2016. And he actually agreed with that hypothesis. He says, if we say that it's an object, let me talk about objects. I'm a big fan of the field of object relations.
Same.
So the strict definition of a fetish is that it's an inanimate object, but I would like to expand that to animate objects, people.
Yes.
So if we take that theory that the object, which is men, masculinity, other males, has caused the individual pain or fear, then it can very well get eroticized.
Yes.
And so I think that the idea that homosexuality could be a fetish is, we have strong evidence in our practices for that. So there's this push-pull, right? So the young man is attracted to masculinity, but he fears it at the same time. So to render the male pleasurable, he eroticizes him.
Yes.
So it fits in with the theory.
So can we dig into that a little bit more? What would cause that fear to then become eroticized?
Sure. I believe trauma causes that fear. So it's early negative childhood experiences from the age of 1.5 or 2 on up through adolescence and through the teen years. And as you know, Andrew, many of our clients have experienced bullying in elementary and high school, fathers who have been hostile, aggressive, or emotionally detached, mothers who have been controlling and intrusive, not allowing the young man to develop his own sense of self and sense of masculinity. So I believe all of that is traumatizing. I also want to say, and we're going to go back to object relations, and I did a video about this, or a presentation on this. There is a high correlation between homosexuality and borderline personality disorder. And borderline personality disorder is a disorder of attachment. So the only way to have poor attachment, in my judgment, is to have trauma. Normal attachment doesn't involve any trauma.
Yeah, that's one of the points I bring up, because I have borderline clients, or clients with borderline, and I really have a bone to pick with the way we discuss borderline, or just personalities in general, as if it's just something you're born with,
right,
and you can't do anything about it. And it's just, well, some people just end up with a borderline personality adaptation or configuration. And it's like, no, people don't just end up borderline. There's core needs that were not met, and then there's punishments, arbitrary punishments for pursuing core needs.
That's right.
And so it goes back to an early age, certainly, but to think that you were just meant to have that dynamic of borderline, of that push-pull dynamic, which we see so much in our clients with same-sex attraction. I want love, but I'm scared of love. I want male attention, affection, approval, affiliation, but I'm scared of it.
Exactly.
And so I push away from it. There's that defensive detachment as well as that craving for it. So we may not always see clients who qualify with the diagnosis of borderline personality disorder, but we certainly see the dynamics to some degree, some extent.
Absolutely. We see them quite frequently.
Yeah. Right. So maybe you can jump in a little bit more. We're moving along pretty well here. With what are some of the treatment approaches that you use to help clients gain that insight into how that trauma got eroticized to become a fetish?
Yes, I do an intervention called intensive body work. And intensive body work begins with a conflict. So the conflict would look like this. When I see a woman, I have this strong urge of wanting her to kick me in the genitals. I literally had a client with that fetish. And what we do is we probe the feeling that occurs underneath that compulsion, that urge, right before the client is going to act out. And invariably, the feelings are negative. They're feelings of hurt, of pain, of emptiness, void, something lacking. And so then what we do is, once those feelings have been brought up to the surface through the intervention, we go to the past to find episodes. And I always ask clients to go before age 18, when they've had these same feelings before, as those that they had before they acted out. So that produces memories. And then we make sense. First of all, we make sense of the fetish as a response to the pain and trauma.
Mhm.
And then we typically do image transformation therapy on the memories that are percolating in their subconscious. It's
Yeah.
those memories, often unconscious now, that we bring to conscious awareness so that we can deal with them.
Yeah.
Also,
No,
there's an aspect, I'm sorry,
oh, I
you're
was
going
going
to,
to say that's so similar to what I do
right.
frequently. Yes.
There's an aspect of repetition compulsion in a fetish. So the fetish results in what I call a reenactment. So if a young man, for example, has had a series of double binds, grown up with lots of double binds, the having another man tie him up is a reenactment of that in the attempt to make it correct or to solve the problem.
Can you dig into that a little bit? How,
Yes.
so someone skeptical of more psychodynamic approaches might hear that and be like, how does that help the client solve anything? They're just repeating the experience.
Well, double binds, as you know, and I like that example, are extremely frustrating. And so the client wants to resolve that frustration, wants the frustration to go away.
Mhm.
And so, of course, when we have a problem, something that frustrates us, if we can resolve it, then the feeling will go away. We'll feel satisfied. So it's this lack of satisfaction. And as you mentioned before, the lack of having needs fulfillment that drives the fetish.
Mhm.
So take the case of transvestic fetishism. Here's a case, and I've had at least 6 or 7 men with transvestic fetishism. The women's garments get eroticized because they represent something and they represent the feminine. So if I can wear it, I feel closer to it. And if I eroticize it, I get rid of the pain associated with it.
Mm.
A lot of people say, oh, men wear women's clothes and masturbate, that's creepy, that's freaky. I said, you can say that, but it has a rationale.
Yeah. Yeah.
In the psyche, it has a rationale, which is I'm going to get close to this object and what it represents so I'll feel better. In fact, I'll make myself feel better.
Yeah.
So how must I be feeling if I have to make myself feel better?
Mhm.
Probably pretty bad deep down.
And could you clarify then how this is different from doing like exposure therapy, where I can imagine some people hearing this and like, well, if they have an anxiety about something, then the standard protocol is to expose yourself to the anxiety or the anxiety provoking stimuli to reduce it. So how is that different from this?
The
Can you
problem
nuance that?
is that in this case, because it's been eroticized, you cannot break the eroticization until you know that it's associated with trauma. So this is less a case of a phobic type situation and more a case of, eroticization.
Yeah. I would also say that you're not really exposing yourself to the real thing that you're afraid of.
Correct.
It's an illusion. The dress is an association, but it represents something else that they're really avoiding. So
Correct.
when we get past what that dress, for example, symbolizes, you get to, say, maternal comfort, for example. And there's the point where there's the trauma and what he's anxious about. And now he needs to confront that. That's what he needs to be exposed to with
And what they
self-regulation.
used to do is they used to try to expose the patient to the same feelings that they experienced in childhood that caused the trauma. But that can actually be re-traumatizing. And
Yes.
so we no longer do that. That I find that counterproductive.
Yeah, what I found is what we need to do is combine self-regulation with exposure. We sometimes feel the urge or there's a tendency or maybe a conventional wisdom to do exposure right away, or like that's the core of it. No, because it is traumatizing or re-traumatizing if they haven't practiced self-regulation first, if they don't have that ability to look at the thing that brought up the trauma for them in a relaxed body.
Mhm.
And that's what I think is so powerful about the image transformation therapy approach, because we first do that pain, terror, release protocol. We get reduce the distress before we go into the image deconstruction. We go into where the worst moment is.
Well, the whole purpose of image transformation therapy is to destroy the image and the associated feelings. And so to ask a client to relive in their body the negative feelings that they had early on, I think is too much. It can be overwhelming. I even was doing intensive body work with a client once, and he began to dissociate. It was so painful. And we need better and more efficient interventions.
Yep. Yeah, I have a particular client I'm thinking of who, when we start just touching on a memory, he's like, oh, I'm on the verge. I'm like, okay, we'll just go right into the body, work on regulating. I'm like, all right, before we go into it and you start spacing out on me, let's just stay right here. Stay with this feeling, relax the body. So it keeps him from dissociating in the session.
Now, I want to bring something up that happened at a conference. I was presenting at a conference of Christians. Most of them were struggling with same-sex attraction. And a woman in the audience during the Q&A said, Mr. Vazzo, you said that where there's eroticization, there's a wound. What about heterosexuality? Is there a wound there? And I said, actually, yes. What happens is a boy is born and he's literally merged to his mother. Then, as he begins to grow, he starts to see people similar to himself, and those are other males. And in the absence of any trauma, he will identify with them. He will actually leave the mother's world and realm and go to the masculine world and realm. And I tell people we tend to identify with people who are similar to us and disidentify with people who are different. That's why we have racism, right? We like people who agree with us politically. We like people of the same skin color. So we have to have conscious awareness to reach out to the other. So a boy will, in fact, go through this process and identify with dad. And then later on, when he reaches puberty, he will see the object that he detached from. Now, this is not a trauma in the true sense of the word. This is what I call an existential trauma, meaning that it's just the result of growth. Nevertheless, there's a separation. And this is why you'll hear men and women talk about their spouses as my other half, my better half, because in fact, they're aware that that's the other part of them that they gave up years ago.
Yes. Yeah, it's another way of putting it. I sort of described it as you still have to be whole enough as an individual. So you're not looking to your spouse to complete you as a man, but rather, since we are called for the two to become one flesh, and it's like you become a new organism.
It's a wholeness. There's
a new wholeness that's formed. So you need the complementary sex to make that new whole. And that urge to form that type of union arises out of a sense of being complete as a man, or if you're a woman, as a woman. So the next stage of your own development is to go beyond yourself and want to create something new.
To the other. Now, interestingly enough, I tell people what causes heterosexuality is the same thing that causes homosexuality, in the sense that the man believes he will be complete with another man. So how must he feel? He must feel incomplete. And as you know, Andrew, in our work, in almost every case of homosexuality, we find a deeply rooted inferiority complex. And so that's the same drive that fuels heterosexuality in a way.
Yeah, I want to pick your brain a little bit about this, because one of the exercises we do in reintegrative therapy is early on, we'll do like the ideal guy, ideal self exercise that helps client become aware of that inferiority. But I do know that there's a bit of a subset, or a couple subsets, that doesn't always like click for them right away. That there are oftentimes, there's one subset which we call twinning, where the guy will be more drawn to someone who is already like him.
Yes.
And then there's those who are more drawn to someone who actually they view as inferior to him, rather than someone, because typical case would be guys who are drawn to someone who they view as more superior to them. So how would you explain that, those types of subtypes there, of someone looking for someone who matches them more and those who seems inferior to them?
Sure. I think it's actually flip sides of the same coin. What's involved in homosexuality, as I've learned over the years, is that the male homosexual has been throughout his life corrected rather than reflected. And by corrected, I'm using the broad sense of the word, meaning that people make comments, especially the primary caregivers, telling him how he should be rather than reflecting how he is.
Mm.
So homosexuality for me is a search for the masculine self. So sometimes he will find that in an idealized male, and sometimes he will see himself in the inferior male.
Mm.
So it's the same phenomena, but different aspects of it. But in both cases, the male has not been reflected. That's
Mm.
why he's going to look for himself, which is why homosexuality for me is intrinsically narcissistic. And I'm using the term narcissistic not to mean selfish, not at
Yes.
all. I'm using it for the pure clinical term in that he's looking for somebody who will complete him and reflect him.
Yes. Yeah. Yeah. Before you all get triggered, all right, there's a
We all
clinical
get
sense.
triggered. I'm not saying men who are homosexual are selfish or,
Mhm.
or self-centered. I'm saying that they're looking for the self in the other.
Yes. It's so.
You see, the father or other males are the conduit for the boy's own masculinity. And if they reflect his masculinity, he will see it and integrate it, and then there won't be any difficulties later.
Yeah. So the same-sex sexual act or fantasy is fulfilling or rectifying a
Attempting
narcissistic
to,
wound.
yes,
Yes.
yes, the narcissistic wound, yes.
So let me get into a little more then. Once we start helping the clients identify where these wounds are and how the trauma uh, brings about this eroticization, what are some techniques you use to help clients resolve that more?
Yes. So as I mentioned, one technique I use, I start first with intensive body work, then I go to image transformation, and I also use the flash technique.
There we go.
Now, the flash technique was developed by Dr. Phil Manfield as a sort of, well, it's turned into a substitute for EMDR, and you're familiar with EMDR.
Yeah.
So what we have learned is that when we sleep, we have rapid eye movement from left to right, and that tends to resolve trauma. It resolves the day's trauma. But some traumas are so deep, and having a fetish is evidence for me of a deeper trauma, that the images and the feelings associated with them remain fixated. So what Flash does is helps the person to kind of break the fixation and the feelings associated with the trauma.
Mm-hmm.
So I might ask a client about a memory that stuck with him. Maybe it's being humiliated. So humiliation can be involved in a fetish. And then we will do flash technique on that humiliation to change the self-feeling. Actually, we change the self-feeling with the flash technique so that the image is less compelling.
Yes. Yeah. That would be more the reinstallation or the installation of a new viewpoint of yourself.
Right.
Now, I'm gonna see what you think about this because uh, the more I do videos on these topics, the more I get people reaching out, and I got a wait list now for clients. And I think there's a tendency as well to think that the only way of getting any progress in this area is to see a professional who's trained in this area. Are there some ideas you have about what someone could do in the meantime on their own, aside from seeing a clinician with specific training
Sure.
and stuff?
Sure. I always tell my clients this. I said, I want you to ask yourself not why questions, not why am I attracted, not why do I eroticize this, but what questions, which is what do I get from that? What does that give me? And how questions, how does that make me feel before and after? And invariably, they learn that the fetish is a sort of affect regulator. So if they're feeling, as you know, listless, restless, bored, anxious, depressed, minimized, humiliated, any of the negative affective states,
All the gray zone stuff. Yeah.
what we call gray zone stuff, they will be tempted to act out on the fetish.
Mm-hmm.
And I would even say that the feelings that they're experiencing as adults mimic many of the feelings they experienced as children.
Mm-hmm.
So there's
Oh
a
yeah.
parallel there.
Yeah, which goes back to why we want to go back to earlier memories.
And we
Oftentimes,
repeat the repetition
yeah,
compulsion.
I usually try even earlier than age 18. I usually direct clients pre-puberty. What are
If
some
we
early
can,
memories? The
if we
earlier, the
can.
better.
Yeah.
Um, what would be some ways that they can start to meet those unmet needs in the present? Aside from just being aware of, okay, well, okay, this is what I get out of it. This is how it feels. What then do they do with that information?
So in the case of transvestic fetishes, and one of my favorite, I tell men, please, whatever you do, if you're dating a woman, don't date a woman who's aloof, emotionally distant, and who makes you chase her, what I call a
Mm,
frustrating object.
mm,
Date a woman different from your mother who gives you your needs. Because remember, the temptation is to engage in repetition compulsion and recreate the same situation.
mm,
So I had a gentleman who actually had a girlfriend who was just like mom. And when she would be distant, absent, uncommitted, he would get frustrated and act out.
mm,
So I tell them to try to get their needs met. If it's a case of something like a fetish involving humiliation, we work on the trauma, processing the trauma, and then that tends to subside. So
yeah.
then, and I also encourage them to engage in self-care, to give them what their parents never gave them.
Now, what about a situation where the dude, he's already in that type of marriage? Yeah, and you're as an MFT, like, do we just up? You're doomed,
Sorry,
or
sorry,
gotta,
Charlie. Tricks are for kids. No,
yeah.
we have to work with him and her.
Mm,
Usually, the wife is the one who says you need to get therapy for this. So
mhm,
he'll come in and I'll bring them both in and say, hey, look, this is the problem. Can you help him with it? You can help him by trying to be warm, empathetic, emotionally close, and maybe keep an eye on your distancing.
yeah.
Right. So we have to work with her too, in that case, in case of transvestic fetishism.
Yeah. So I wonder, that gives us a good outline of all this stuff. I wonder if there's any other cases or unique types of fetishes or ones that maybe some that are very common to types of clients you work with that you can use as some examples to flesh out a bit.
Sure. I've had clients with underwear fetishes, male underwear fetishes. And
Mm,
so we talk about what, that represents, what that does for them. They'll tell me, I feel more masculine. I feel like I look better. I feel more male. I feel stronger. And so then we, of course, then do the body work and then find out, what the deeper need is down there.
yeah,
What's
I've experienced that with
interesting,
some clients as well. Yeah.
right? What's interesting is when we do the body work, I have to be very careful because the initial feelings, as you know, that they experience are pleasurable ones.
Hmm.
If I say, I want you to imagine right before you're going to act out what the feeling in your body is, often they'll say adrenaline rush, anticipation, excitement. And so
Hmm.
then what I do is I go to what need is there?
Yeah.
And then what's the feeling underneath the need? And of course, as you know, those tend to be negative feelings.
Yeah. Oftentimes I try to direct clients to when you first got the idea to act out, what
Mm-hmm.
was the feeling you had? So before you
Exactly.
started really going to that preoccupation stage, what was the emotional state right before the idea popped in? Ooh, I'll go do this to comfort myself. What was that? It takes training. Some people
Well,
to
yes,
get
because
aware of it.
as you know, one of the defenses that they put up when we do intensive body work is to go to their head.
Hmm.
So, how do you feel? I feel like leaving. I feel like running away. I feel like, and those are all ideas.
Yep. Yeah. So probably a good bulk of my work is training people to understand the difference between a thought and a feeling.
Right.
And like this is like elementary stuff, things we learn in kindergarten, but boy, it is so critical just for life in general, that people need to be retaught this stuff as adults, what an
Yes.
emotion is, how it's
Yes.
experienced in the body. So many times, I feel ashamed. Okay, where do you feel in the body? In the body. They're like confused by that question.
Absolutely.
If you're not feeling your body, then it's not an actual feeling. That's where we get the
Mhm.
word feeling from.
Now, interestingly enough, as you know, fetishes can become compulsive. And
Yes.
then we know from obsessive compulsive disorder, that compulsions, the purpose of a compulsion is, again, to block, it blocks deeper feelings associated with the behavior. So often with OC behavior, there's pain and terror. Well, pain is an aspect of a fetish.
Yes.
So interestingly enough, all of this stuff is connected in some way. So fetishism is connected to obsessive compulsive disorder. That's connected often. It's an anxiety disorder.
Yep.
And where there's anxiety, there's depression. And so once we jump on the fetish merry-go-round, we find all sorts of other things there, right? That they're connected to.
Which is this uh, converges quite well with another recent interview I was doing with Michael Gasparo. And so I was talking to him about OCD and same-sex attraction and the relationship between them. So when you have a client with a fetish, whether it's same-sex attraction based or just opposite sex attraction or just wherever on the range, how much of the time do you see that there's co-occurring obsessive compulsive disorder?
Most of the time. It
Mm.
might not be a full-blown obsessive compulsive disorder, but as I said, in clients who come to see me, that means the fetish is strong enough, it's disturbing them, becomes quite compulsive.
And do you find that you have to treat them concurrently or separately or one before the
Well,
other?
as you know, intensive body work is a psychodynamic intervention. Image transformation therapy is great for anxiety because the protocols themselves help lessen anxiety. So I would say simultaneously.
Okay.
I would say simultaneously.
And I guess let me also just, for my own interests with working with some clients, and something I've been noticing as well, just in general, among guys with same-sex attraction, there is a bit of a trend toward foot fetishism.
Yes.
And what is there anything particular about same-sex attraction that makes someone a little more apt to fetishize feet? Where does that come from? What's the connection?
That's a very interesting fetish, and it often has different causes. So you mentioned David Pickup. My good colleague David Pickup had a client who was kicked by his brother, and he had a foot fetish. Other men have told me they remember seeing guys play kickball and they had hairy legs, right? Or football or soccer. And so then the foot or the leg is a fetish, but it even goes deeper than that in what it represents. So it represents masculinity, right? So that's one of the more, for me, I find that a complex fetish. I'm always interested in knowing and finding out what it's connected to. It's not a universal. In other words, it may be that they were kicked, but it may be that a man's hairy foot represents masculinity. It could be.
Yeah. Another one idea that was posited was that the foot is the furthest from the face. And the face is when we're full of shame, our face is downcast. We avoid eye contact with others. We don't want to see someone else's reaction toward us. So we're going to divert our attention toward what is furthest from someone else's face.
Interesting.
So that could be just, in another way, I could look at it as a fetish as being eroticized shame.
Yes.
So, all right, that brings me to greatest shame. I'll look at the feet. That's all I'm worthy of. Because I see a lot of times with the foot fetish that there's like this worship of the foot. So I'm only worthy of this, so I will pour all my admiration into that. But it's particularly difficult when the client doesn't quite make the connections and there's low insight there.
It's a real puzzle, actually. That's what I love about this work is even though I've been doing this for years, I keep a very open mind about what the fetish means for their particular client, what the object that's getting eroticized means.
So with our approaches, I think it's most suited for that individualized type of treatment because we're not positing an explanatory model on the client. Like, oh, this is what it is. You have to accept this, or else like treatment's not going to work. It's the client discovers for themselves what the root of that eroticization
is. They teach us. We have hypotheses, but we have to keep an open mind and let them teach us about what it really represents for them. That's right.
Well, This has been amazing conversation so far. I just want to know if there are any other tips you have for therapists, clients working with these with fetishes, whether they're just the same sex attraction itself or some of the other more
Mm.
divergent fetishes.
I
Any other?
like to tell some of my clients have gone to other therapists, and the
Mm,
approach has often been sort of a cognitive behavioral one where, well, this is causing you problems. So maybe you need to, put it out of conscious awareness or focus on other things or distract yourself. And I really don't believe those interventions work long term. I call those
no.
band-aid interventions.
Yeah, it sounds like more avoidance.
Or you really don't have a problem. You just think you do. You're making it a problem. Lots of people
Mm,
have fetishes. We hear this a lot. In fact, in the Diagnostic and Statistical Manual, it's not a mental disorder unless it causes the client distress or interferes with social and occupational functioning. I
mm.
find that very narrow.
Well, also that's our clue where they're heading next. With most likely DSM-6, they're going to try to just take it out of the DSM in general, most likely.
Right.
Because I remember when they're working on DSM-5 and I was in grad school and my psychopathology professor was actually transgender. And all of a sudden, she, who presented as he, when we got to the sexual disorders, became way more animated and way more enthusiastic about this chapter. Like, this person never really showed a whole lot of enthusiasm about any other chapters, but this one got really interested and was so happy to say that there's been a concerted effort to depathologize the paraphilias and all the different sexual disorders. And of course, what we see with the DSM-5 was gender identity disorder taken out, replaced sort of with gender dysphoria, and just more and more of the criteria for any of the paraphilias be getting stricter and just more and more of a banishment of anything that we often see our clients coming in for being viewed as an actual disorder.
Right. One of the worst things you can tell a client is this shouldn't bother you. It's normal. And
Yeah,
of course, they know deep down it's not, but they're not able to get to the root of the problem. You
yeah,
see, if my hypothesis is correct, paraphilias are the result of trauma. So we have an obligation to our clients to treat the trauma.
yeah. But if they're
If
told that the outcome of the trauma is normal, then it questions what they know to be true, that no, there's something abnormal in my experience that brought about this outcome. No, 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 that's a normal outcome. No, it's not. There's something else there. So it puts clients in this cognitive dissonance with themselves and the rest of
yes,
the world.
yes. The problem, Andrew, is it's very hard to do research on this. So, how do you prove trauma? I suppose you can do these interventions, but they're very subjective.
Mm,
And memories, often clients don't remember anything. Uh, so, there's no way to do a questionnaire on a lot of this. You
yeah.
wouldn't get any, I don't think you'd get any solid data. And so the profession is, well, if there's no research supporting your assertion, you're standing pretty weak, Robert. And I
Mm.
say, look, that's all I know is that my clients feel better and function better after I've done these interventions. So there must be something to it.
I think
They,
right there that shows how important worldview is,
Mhm.
because right now what we're operating in is more and more the postmodern worldview in the psychological institutions, where something is only a problem if the person feels bad. But from an integrated worldview, we understand that there's natural law, that there's a way, there's an objective standard for how people should function. And if there's a way in which someone deviates from that, the normal, what's normal, the normative functioning, sexually
Right.
speaking or otherwise, then there must have been something that veered them off that course.
Correct. When you
But
take
that requires having a standard, some sort of objective view of things.
right, it would be the equivalent of having a cold or a virus and saying it's not a real problem unless it bothers you.
Yeah. Yeah.
I don't buy that.
People get runny noses all the time. That's nothing. That means nothing.
Or prostate cancer, right? Prostate cancer is one of the slowest growing cancers, and they often leave it untreated because you could do more damage treating it than not treating it, but it's still cancer.
Yes. So, no, I hope this is going to be enlightening for people. This is a lot for people to mull over. So, Robert, I just want to thank you so much for this
Oh, thanks
conversation.
for having me.
Yeah, and I love the opportunity to bounce some ideas off you, and I'm
Absolutely.
happy that they've been validated in different ways. So, I just hope more clinicians get outside the box of what the narrative is when it comes
Yes,
to sexual disorders or complaints about sexual experiences, and begin really being more curious about, well, what could be underneath it for the client, and how can I
absolutely.
facilitate that journey for them?
Yeah,
So,
that's what we need to do more of.
all right. And how, if people want to find out more about your practice or any of your work, is there any way you want to put out some information about yourself and how people can find
Yeah,
you?
they can Google me. Just put Robert Vazzo therapist, and my Psychology Today posting will come up. And I also have a posting in Christian Counselor Directory.
Okay.
So there. Uh, my situation is similar to yours. I don't advertise much because if I did, I don't know what I would do with clients. I have a
Oh,
wait list also,
yeah.
and I would probably have 40, 50 people on it. So until I get an intern or somebody who can help me, I have to keep a kind of low profile.
I Here I am. I'm like putting myself out there. I'm like, I know I run the risk of attracting more people, and the problem is so many people come to me. I put them on a wait list, but also there's not enough other therapists I know of that I can direct them
Yes,
to who also
yes.
have availability because I know a bunch of others that are probably full as well.
It's very demoralizing to a client to see that you're
Yes.
putting yourself out there. So then they call and then you have no availability for 2 or 3 months.
Yeah.
It's
So I
demoralizing.
my hope is to inspire more therapists. And so that's what I'm actually engaged in now is training more therapists up because I'm like, I'm not greedy. I want more therapists out there doing this type of work. I
Exactly,
don't want to hog
exactly.
these clients to myself. I want to train more people so I can have a network of people I can refer them to.
Yeah. I just had a little memory come up of one thing I wanted to just say briefly.
Sure.
For me, Andrew, pedophilia is a fetish. And the
Yes.
object that gets eroticized is a child, and there's reasons for that. And I have found some of my interventions very effective in treating pedophilia. I had a gentleman come in. We must have done only 3 or 4 sessions. He came in the next session in tears, and
Mm,
I had assumed that things got worse. He said, "It's gone." I said, "What's gone?" He
mm.
said, My pedophilia, it's gone. I don't have it anymore. I said, "Are you serious?" I really didn't believe him. And after the session, I said, we should meet one more time. I want to make sure it's really gone. And sure enough, it was.
Yeah.
So
I've had
they
a similar
are
experience. I've had,
treatable.
yeah, clients with
Everyone's
pedophilia,
different.
OCD, as well as actual sexualization. And it was a lot of times he was eroticizing his own lost childhood.
Absolutely. That's it exactly.
Yeah. No, that's great. I just, if anything, I want people to know there's hope.
There's
So
hope.
people just, therapists need to start getting outside the box and realizing there's
Absolutely.
not all these conditions are ones people just have to live with.
Exactly. There's hope for them.
Robert, once again, thank you so much. I had a
You take
blast.
care now.
You take care.
Bye
Bye.
bye.
Oh man, I'm just so happy with this interview. Uh, it just helped validate some of the things I've been thinking and talking about in my recent videos, such as this one about what we can learn from Carol Wojtyła's book, Love and Responsibility, and how that relates to same-sex attraction. And just some ideas about in general when it comes to our sexual interests, whether you're attracted to men or women as a male or female, if that interest is not in the true desire for a true union with the other to form the whole that is marriage, but it's rather a fixation on an aspect of that person or the way in which that person reminds you of some, like we said in the interview, an object, like an internalization of earlier relationships, then that would qualify as a fetish. So I hope you hear that, though, from a place of our concern and not condemnation. That the reason we offer therapy for those who are struggling with their sexuality is not discriminatory. It's not from a place of hate or demonization, but from a place of deep concern for your own well-being. So, before I sign off, I just want to make sure you know that Jesus loves you freely, fully, faithfully, and fruitfully.